Hey everyone, and welcome back to Decode Healthcare with Harshal. You are tuning in to part 65 of our massive 100-part series. Today, we're doing a deep dive explainer on the ICD-10-CM official guidelines. Now look, while textbooks like Buck's Step by Step are fantastic for building a foundation, we really need to set the record straight today. We are declaring the CMS official guidelines for coding and reporting as the absolute undisputed source of truth. Seriously, when it comes to conquering audits and ensuring compliance, the official guidelines strictly override any textbook, period. So grab your notebooks, because today we are absolutely mastering Chapter 21.
So, let me ask you a question. When does a diagnosis code not actually represent a disease or an injury? It's kind of an intriguing thought, right? Well, the answer lies in Chapter 21, Factors Influencing Health Status and Contact with Health Services. In the medical coding world, we universally know these as Z codes. And Z codes are absolutely vital because they tell the complete clinical story of a patient encounter. They capture all those circumstances, statuses, and social factors that go way beyond just a traditional medical diagnosis.
To get a handle on all of this, here is our agenda for today's explainer. We're going to cover first listed versus secondary Z codes, then the screening sequence law, status versus personal history, social determinants of health, and finally, we'll wrap up with the non-physician exception.
All right, let's jump straight into Section 1, first listed versus secondary Z codes.
You really can't just slap a Z code anywhere on a claim form. Our very first law today involves understanding the strict hierarchy of Z codes based directly on the CMS guidelines. Their sequencing is highly regulated. So we've got a clear division in the Z code universe. On one side, we have first listed only Z codes. These are codes that absolutely must lead the claim. They have to be in slot number 1. We're talking about examples like Z00 for a routine general wellness exam, or Z01 for a specialty exam without a reported diagnosis. But on the flip side, we have secondary support-only Z codes. These strictly function as supporting characters. They can never lead a claim. Examples here would be Z95.1 for the presence of a KEBG graft, or Z99.81 for long-term oxygen use.
And the official guidelines? They do not leave this up for debate. CMS explicitly states, and I quote, "Certain Z codes may only be used as first listed or principal diagnosis." That is a mandate. Whether it's Z30 for contraceptive management or Z38 for a live-born infant according to the place of birth, if the guideline dictates it must be first listed, it has to be first listed. Missequencing these codes is honestly one of the fastest ways to trigger an automatic denial from a payer.
Moving right along, let's hit Section 2, the screening sequence law.
This leads us to one of the most misunderstood rules in the whole profession. Before we even assign a code, we have to understand the exact clinical definition of a screening according to Section I.C.21. A screening is a test performed on an asymptomatic patient, meaning a seemingly well individual, specifically to detect a disease early. The intent behind that test entirely dictates how you're going to sequence your codes. If a patient comes in with a symptom, let's say abdominal pain, and gets a test, that's a diagnostic exam, not a screening. But if they are perfectly healthy and just coming in for a routine check, that is a screening.
So let's say a patient shows up for a routine colonoscopy. They have 0 symptoms. Because of that, we use a screening Z code, Z12.11, right there in slot number 1. But wait, during the procedure, the physician discovers an abnormal finding, a colon polyp. Now, your first instinct might be to bump the polyp up to the primary diagnosis because, well, it's a disease, right? Actually, no. The screening rule dictates that the screening Z code stays in slot number 1 because that was the original intent of the encounter. The newly discovered polyp, K63.5, gets stacked as a secondary diagnosis.
Okay, let's shift to Section 3, status versus personal history.
This third law is absolutely crucial for avoiding major audit flags. It forces coders to clearly distinguish between what is happening to the patient right now versus what happened to them in the past. So first up, we have status codes, which live in categories Z93 through Z99. A status code indicates that a patient currently has a continuous clinical state or a prosthetic device. We're talking about an active, present state that is informative and directly affects their ongoing treatment. Think of things that are physically present with the patient today, like Z93.0 for an active tracheostomy status or Z95.2 for the presence of a prosthetic heart valve.
Now compare that with personal history codes, which you'll find in categories Z85 through Z87.
History codes indicate a condition the patient previously had but has been completely eradicated or fully resolved and literally no longer exists. The patient isn't getting treatment for it right now, but it still holds a lot of clinical significance for their future care. A classic example of this would be Z85.3 for a personal history of a malignant neoplasm of the breast.
The huge takeaway here, and honestly, the reason this turns into a massive compliance issue, is that swapping these two concepts is a severe error. The active present state is your status code. The cured past condition is your history code. If a patient has a completely resolved case of lung cancer, they get a history code, like Z85.118. If you accidentally assign an active disease code or confuse a past history with a current status, you are painting a wildly inaccurate clinical picture. And let me tell you, that will immediately trigger a compliance audit.
Let's pivot a bit for Section 4, Social Determinants of Health, or SDOH.
So looking at categories Z55 through Z65, we step into the modern landscape of medical coding. Social determinants of health codes capture the vital socioeconomic hazards that directly influence a patient's health outcomes. We're talking about capturing real-world economic struggles, housing instability like Z59.0 for homelessness, environmental risks, severe poverty under Z59.5, and all sorts of psychosocial factors. And why does this matter so much? Because capturing these SDOH codes deeply impacts risk adjustment scores and health equity analytics. It paints a complete, holistic picture of the patient's environment, and it explains to payers and providers exactly why a patient might be struggling to manage their chronic conditions.
Which perfectly sets up Section 5, the non-physician exception.
This is a real game changer. Normally, in medical coding, the golden rule is that a diagnosis has to be documented by the patient's provider, the physician, or a legally accountable practitioner. For standard diagnoses, yeah, you absolutely require a provider note. But for SDOH Z codes, the CMS guidelines grant a phenomenal exception. You are explicitly allowed to extract SDOH Z codes from documentation provided by any member of the healthcare team involved in the patient's care. This includes clinical social workers, nurses, case managers, and even community health workers.
Let's walk through exactly how this plays out in the real world. Step 1. A clinical social worker writes a note in the chart stating the patient is currently unhoused and experiencing severe food insecurity. Step 2. As the coder, you do not have to wait for the physician to copy and paste that into their own note. You can assign Z59.00 for homelessness and Z59.41 for food insecurity straight from the social worker's documentation. Step 3. Green compliance check. You are fully supported by the guidelines in doing exactly that.
And if anyone pushes back on you for doing this, here is your absolute proof. Check out this direct quote from Section IB14 of the official guidelines. Code assignment may be based on medical record documentation from clinicians involved in the care of the patient who are not the patient's provider. This specific exception for SDOH codes means the official guidelines have your back. It empowers coders to make sure that vital social data isn't just lost simply because the attending physician didn't write it down themselves.
All right, let's bring it all together in Section 6, Key Takeaways.
We've covered a ton of ground today, so here's your rapid-fire, zero-fluff summary of Section IC21. Number 1, the CMS official guidelines always trump your textbooks. Number 2, the sequencing of first listed versus secondary Z codes is a strict, undeniable law. Number 3, the screening Z code always leads the claim, even if a pathology is discovered during the test. Number 4, status codes mean an active present state, while history codes mean a cured past condition. Never ever mix them up. And number 5, SDOH codes are your one big exception where you can confidently pull diagnosis from non-physician documentation. At the end of the day, accurate documentation combined with a strict adherence to the rules equals absolute compliance. Relying entirely on the CMS official guidelines is literally the only way to ensure bulletproof accuracy in your coding career. Master the guidelines and you will conquer the audits for sure. So, I want to leave you with this one final thought to ponder today. Are your current coding practices strictly following these absolute Z code laws, or are you falling into those textbook traps? Take a hard look at your recent claims and audit your own practices. Thank you so much for joining me for this explainer. Keep studying those guidelines, stay focused, and I will see you next time for Part 66 of Decode Healthcare with Harshal.